So I'll take the opposite view. I was supposed to be, this is supposed to be Jeff Lancet's, but as you know from Hurricane Irma, he was unable to show. So should MRD routine and AML be routine? This is the argument against. I just want to give my disclosures here, which I gave them before yesterday. They haven't changed in the days since yesterday's talk. And a special thanks to Jeff, who really helped me prepare this talk with slides and discussion. So let's start by asking some key questions about MRD. First of all, what is it? How can you measure it? Does everyone measure it the same way? And how much does it cost? A factor that I think that's very important. But I think the most important point is, does it change your decision making? We've talked about that, and this is a non-APL MRD, just to reflect. And I would argue that if a patient is MRD positive, we really do not know how to act upon this. This is not ALL, this is AML, where the pediatricians have shown repetitively that MRD positive and ALL at the end of induction, you can dose intensify and improve outcomes. And I'll show you some data here to the contrary. Secondly, Dr. Jabbour yesterday showed from the German data that blinatumomab is an effective modality in treating MRD relapse or refractory MRD in patients with ALL. So one assumption that we have is, as we enter the era of novel and targeted therapies in AML, we have to refine the sensitivity and applicability of MRD. There's little doubt that MRD will emerge as the most powerful prognostic marker, and my colleague Dr. Walter just showed in his elegant discussion why that is true. But I think it does not answer the question, and I do not think he answered the question adequately, of whether this should be used universally today by every center. So what is MRD? It's a name given to the small number of leukemic cells or cancer cells that remain in a patient after therapy or after treatment when a patient is in remission. If complete remission is defined as less than 5%, then this value is some 10 to the minus whatever number to less than 5%. And the idea here is to try and predict relapse. The deeper remission, theoretically, at some point we should be able to get a patient into cure. That's really what we're here for, is to try and get a patient into cure and to change therapy in a patient who has received ineffective therapy, that is, still has residual disease, in order to try and cure them. So I think it is important to focus on how MRD is being measured, whether it's multicolor flow, RT-PCR, or next-generation sequencing. Do you use these different assays in your own institution? One can ask. Do you use the results to make clinical decisions? That is, more therapy, less therapy? Do you change therapy? Do you refer a patient to transplant? Or do you not refer a patient to transplant? I think these are the critical questions that need to be addressed to answer the question of whether MRD should be part of routine clinical care. So just a few seconds on different assays, because I want to focus on the last column in red, flow cytometry. Most institutions, including our institution, have a 4 to 6 color approach, which is not as ideal as my colleague from Seattle, which uses a really multicolor, very sophisticated approach. So there's no standardization. I think that's an issue. It requires expertise, as we've already heard. And there are immunophenotypic shifts, making flow cytometry difficult to interpret. What about RT-PCR? Undoubtedly more sensitive, but it's not valuable in all AMLs. Clearly APL, as Dr. Katarzian has mentioned, but I'm focusing on non-APL AML. And some abnormalities, some genetic abnormalities may persist in the non-leukemic stem cell, which may make interpretation somewhat difficult. What about next generation or deep sequencing? Well, again, this is very expensive. It costs a lot of money. It takes a lot of time. And not all mutations will track with the blast or the leukemia stem cells, and not all mutations will persist at the time of relapse. So considerations regarding MRD and AML, again, morphologic response may have negative flow MRD. We just saw some data from Dr. Walter. The threshold of clinically relevant MRD changes with time. When do you measure it? At the end of induction, at the end of consolidation, after how many rounds of consolidation? And then there are discrepant results between those patients, between flow and molecular results, specifically in the core binding factor data. And then the distribution of MRD in the bone marrow is somewhat heterogeneous. And this is just a slide that I borrowed from Dr. Pieta, looking at the heterogeneity in patients in remission of where you sample. So a bone marrow sample at one spot in the iliac crest may give you a very different sample from another spot. To quote my colleague, it is a common misconception that technical improvements in MRD assays will eventually eliminate false negative MRD. Rather, it's the ability to detect low levels of residual leukemia, primarily by the character and the size, very important, and the size of the biologic sample that's being tested. So what are the challenges? What time points to measure, as I've alluded to? How often to monitor? Standardization, I think, is critical. How much MRD is positive? At what threshold do you make a decision to change therapy? And what do we do with the information? As I've alluded to, there's no blinatumomab yet approved for AML. So this is just some data. This is more in the pediatric data, showing the difference between residual disease and non-residual disease, or RD. And here there was no difference in the relapse-free survival depending upon whether the residual disease, or MRD, was 0 to 1%, or greater than 1%, arguing that, again, what level of MRD is important? Again, using multicolor flow in the pediatric regimen, there seemed to be no data in terms of predicting in the core binding factor mutation subpopulation between residual disease and those who were MRD positive in terms of the relapse-free survival.